All right, hello. It is week 5 of the MSN 836 Advanced Pathophysiology Across the Lifespan course, and this week we are going to talk about one disease only, and that is diabetes mellitus, a disorder of glucose metabolism. Why are we going to spend an entire unit just on diabetes mellitus? Many reasons. About 10% of the U.S. population has some form of diabetes mellitus. About another 20 to 25% of the U.S. population, and probably even higher, is in a state of pre-diabetes mellitus. And diabetes mellitus is one of the most important risk factors for cardiovascular disease. As we will see in this presentation and in the required readings, diabetes mellitus is a metabolic disorder of glucose metabolism, but it is truly a pathophysiologic disorder of blood vessels. And as we need blood vessels to provide adequate oxygenation of all tissue, diabetes mellitus can have adverse effects on all tissue within the human body. Couple of readings I want you to take a look at. Chapter 21, please read up a little bit on the two pancreatic hormones, insulin and glucagon. We'll get into that in this presentation and look at how the two oppose each other, where insulin lowers blood glucose and glucagon raises blood glucose levels. And then within the endocrine chapter 22, pages 735 to 752 are devoted solely to diabetes mellitus. I would like you to take a look at those pages as well. And then I have a couple of things up on Blackboard that I want you to read. Two very quick files, one on diagnosing diabetes mellitus and one on case scenarios of type 1 and type 2 diabetes mellitus. Those are both one-page documents that I wrote for you guys that I want you to take a look at. And then there's a huge document, 236-page PDF file called the Wisconsin Essential Guidelines for Diabetes Mellitus Care. That's a reference PDF for you that you should keep throughout your career. That is the most recent guidelines put out by the state of Wisconsin, and it is everything about the care of patients with diabetes mellitus, and we will talk more about that guideline as we move through the PowerPoint presentation. And again, I don't expect you to read a 236-page document, but I am going to highlight some points in that document that I would like you to take a look at, and I certainly want you to keep that in your reference files. Doesn't matter what subspecialty or primary care area that you plan on going into in your future, you will always be encountering pediatric and adult patients with diabetes mellitus. All right, let's talk about the pancreas for a minute here. The pancreas is the source of the two hormones insulin and glucagon, which play a huge role in glucose metabolism. That's the endocrine pancreas. Those are hormones being secreted by the pancreas into the bloodstream, having their effects on other organs. The exocrine pancreas, the part of the pancreas that is producing digestive enzymes, we're going to talk more about that when we get into the GI section. For now, we're going to focus on the endocrine pancreas. How do you find the pancreas? The pancreas is in the abdominal cavity. It is above the umbilicus, located centrally. It is under the liver and behind the stomach. If you look at the CT scan on the lower right, the pancreas is at the yellow arrow. The stomach is the red dot. The gallbladder is the green dot. Liver is the blue dot, two kidneys are the yellow dots, and then the vertebral body is the orange dot. And if you look at the graphic on the lower left then, you see that blue line. That blue line kind of represents where that cut of the CT scan was taken. So we're looking at the body in a transverse section, and this particular cut here very nicely showed the pancreas in that image. So what just happened there? Look at, first off, let's talk about glucose. Glucose is the monosaccharide, extremely important carbohydrate, and probably our prime energy source. And we'll talk more about glucose as an energy source. Glucose has a lot of hydroxyl groups on it. You can see all that OH groups on glucose. That makes it very water soluble, very polar, and it's difficult for glucose to move from blood across the cell membrane into the cell where it's going to be used as the energy substrate. So we need insulin to make that happen, and we'll talk about the mechanism of how insulin facilitates glucose transport. The graphic that I have in the middle shows what our pancreas does with respect to insulin secretion. So we are always secreting a small amount of basal insulin over the course of the day. And then depending on how much carbohydrate we ingest and how high our blood glucose then rises as a result of the sugar and carbohydrate that we ate, then the pancreas is going to pump out more insulin to accommodate that additional glucose that we ingested. And so then you can see the spikes or the bolusing of insulin release from the pancreas. The more glucose we ingest or the more carbohydrate that we ingest, the higher the blood glucose, the more insulin that we are going to pump out of our pancreas and put into the bloodstream. And again, the goal of insulin is to move glucose out of the blood and into the cells so it can be used as an energy substrate. So what is diabetes mellitus? Diabetes mellitus is a defect in the insulin system. Either we have no insulin or the insulin that we have is faulty, meaning we don't have enough to compensate for the blood glucose that we have, or it just doesn't work. And we're going to differentiate these two different types as type 1 and type 2, where type 1 is we just don't have any insulin, and type 2 is we have insulin but it's not doing its job, or we have insulin and we're just not getting enough of it out. If we don't have insulin, or if we have insufficient working insulin, then the clinical manifestation is going to be hyperglycemia, and hyperglycemia is elevated blood glucose levels. So why care? So what? We've got some excess sugar floating around in our blood. Why is that bad? We're going to look at why is that bad in a little bit of molecular detail. Elevated blood sugar in blood vessels will bind onto critical proteins within those blood vessels and begin to set up a fairly devastating inflammatory process. And the damage to blood vessels is what results in the clinical consequences in the end organ pathology of diabetes mellitus. Small blood vessels, large blood vessels, and long neurons are the most adversely affected due to that elevated blood glucose. So we talk about microvascular pathology. Those are small blood vessels, typically the capillary beds. Macrovascular pathology, larger arterioles being affected by elevated blood glucose. So when we're talking about diabetes mellitus, while diabetes mellitus is in fact a metabolic disease, the consequence of that metabolic disease is vascular pathology. So please take a look at video 1, and that will define for you a little bit more this concept of what is diabetes mellitus. Okay, so here are some blood vessels, and if you look at the upper right picture, that's the histology of a blood vessel. And you can see the blood vessel has a number of different layers. The most inner layer of the lumen is referred to as the tunica intima. Blood vessel is surrounded by smooth muscle referred to as the tunica media. And then on the outside of the blood vessel connective tissue layer, the tunica adventitia. And when you look at that picture, you can see that that blood vessel is nice and open, right? Blood should be flowing through that vessel very easily. Now look at our two lower pictures, and you can see that the lumen of that blood vessel is starting to become occluded. And that occlusion of the blood vessel is occurring due to plaquing, and that process is referred to as atherosclerosis. Atherosclerosis is complex and heterogeneous. Heterogeneous meaning that there are a lot of things that are accumulating in that plaque. Let's name some types of chemicals that are accumulating in that plaque. I think everybody knows that we have cholesterol accumulating in that plaque. Other types of low-density lipids are accumulating in that plaque, carbohydrates, fibrotic cells, inflammatory cells. A lot of things are happening inside that fibrotic plaque, and the more and more that plaque accumulates, the more it encroaches on that lumen, and as it encroaches on that lumen, it begins to inhibit blood flow to the end organ. We'll talk more detail about atherosclerosis when we get into cardiovascular units. A critical risk factor for atherosclerosis is diabetes mellitus. Again, diabetes mellitus is a vascular disease because it enhances the risks and the rates of atherosclerotic plaquing, say that 3 times fast, atherosclerotic plaquing within the blood vessels. AGEs, advanced glycation end products, is something we'll talk about in a couple of slides, and we'll see how glucose plays a role in developing these AGEs, which are important in the development of the plaquing process. Here's some examples of the vascular pathology of diabetes mellitus. Again, diabetes mellitus is a vascular disease affecting small blood vessels, microvascular, and affecting large blood vessels, macrovascular. So look at the blood clot in the coronary angiogram in the picture labeled A, and next to it you can see that plaquing, which is occurring within that artery, kind of in the middle of the picture. In the middle picture, those are actually showing signs of diabetic nephropathy, so damage to the kidneys due to the damage which is happening to the vasculature within the kidneys, showing the normal kidney on the left and the abnormal kidney on the right, both in histologic and in gross pathologic section. Look at the effects of diabetes mellitus and vascular disease on blood vessels in the extremities, and we will talk about ischemia of the foot and diabetic foot ulcers. And then look at the normal retina on top and the diabetic retina on the bottom, and you can see a lot of hemorrhage and other inflammatory responses. Again, that shows you the direct consequences of diabetes mellitus on blood vessels. And this is something that can be easily seen by examining the retina. You can see all that damage being done to the retina. Now apply that to almost any other tissue in the body, and you can see why diabetes mellitus is considered to be a vascular disease. And we'll get more into detail about this as we move on. Let's talk about the burden of diabetes in the United States. Here you can see some numbers that comes from the Center for Disease Control. Look at the total amount of individuals in the United States affected with diabetes mellitus. Right now we're about 10% of the US population with having a diagnosis of diabetes mellitus, and estimated that about another 20 to 25% may be walking around with silent diabetes mellitus or pre-diabetes mellitus, which we'll talk about in a couple of slides here. Under the age of 20, diabetes mellitus is not too common, 1 in 400 estimated, and most of that is type 1. Once you get beyond the age of 20, and certainly once you get beyond the age of 65, you can see what's the percent of the population then who suffers from diabetes mellitus. So a very, very big burden within the United States and globally. This is the state of Wisconsin by county, and this comes out of state of Wisconsin public health data, and it shows you the percent of adult patients within the county diagnosed with diabetes mellitus. And the darker the county, the higher is the percent population with diabetes mellitus. So it doesn't matter where you're going to practice, whether you're going to practice urban, whether you're going to practice rural, something in between. You can see that our state is pretty well hit with individuals who suffer from diabetes mellitus. Here's something that you can share on Blackboard. You've all been in the nursing profession for a while. Think of how many patients you have seen so far in your nursing career with diabetes mellitus, and comment about the ages of these patients. Have they been primarily pediatric, young adult, middle adult, elderly adult? Let's get a little bit of discussion out there just to kind of prove to ourselves that we already, as practitioners who have already practiced and practitioners who are advancing in our careers, let's just talk a little bit about how much diabetes mellitus we have already seen in our different practices. All right, so more data coming out of the Center for Disease Control, saying that about, at this point now, almost 30 million people living in our country with diabetes mellitus. That's 1 out of every 11. 1 out of every 4 people may have a condition referred to as pre-diabetes mellitus and not even be aware of it. We'll define that in a second here. Lower panel talks about pre-diabetes mellitus, about 86 million people with that. And very important, when we're talking about pre-diabetes mellitus and even the full-blown diabetes mellitus, we need to talk about healthy lifestyles, particularly weight loss and physical activity, as a way to prevent this and help reverse the pathology that one may already be suffering from should they already be diagnosed with diabetes mellitus. Cardiovascular disease is the leading cause of death in the United States. That is due to atherosclerotic plaquing. So you can see some graphics here of what that looks like, both in animated and in histologic section. The more plaque put in those arteries, the more blood flow is reduced. And as blood flow is reduced, we begin to have ischemic damage to the end organ. In a heart, atherosclerotic plaquing, which inhibits blood supply, leads to ischemic damage of the heart muscle. That's referred to as a heart attack. So a major macrovascular complication of diabetes mellitus is heart disease, particularly myocardial ischemia, and we'll talk more about the vascular consequences of diabetes mellitus. Please take a quick look at video 2. Talk to you a little bit more about the clinical consequences of diabetes mellitus. All right, so we've got 2 hormones in play here. We've got insulin being secreted by the pancreas. It's secreted by specific cells referred to as beta cells. And then we have glucagon being secreted by the pancreas, cells referred to as alpha cells, and they oppose each other. When blood sugar levels are high, pancreas will release insulin, and insulin will move that glucose into cells so it can be used as energy substrate or stored as energy substrate. Most commonly, that blood glucose is going to be moved into cells and then be stored as a complex carbohydrate glycogen. Glucagon going to do the exact opposite. When blood sugar levels are low, pancreas will release glucagon. The primary effect of glucagon will be on the liver and skeletal muscle. We will then start breaking down that stored glycogen into glucose, release that glucose into the bloodstream, thus raising blood glucose levels. So you can see insulin and glucagon kind of working in opposition, but doing that to maintain homeostasis, doing that to maintain a normal range of blood glucose levels and making sure that our cells are being adequately fed with that energy substrate glucose. What do insulin and glucagon look like? Again, they are two hormones that come from the pancreas. These are protein hormones, and as you remember from some biochemistry, a protein is made up of chained amino acids. Start chaining amino acids together, and you end up with small peptides, bigger peptides, right? Peptide, another term for protein. Glucagon is a single chain. It consists of 29 amino acids, and there you can see the sequence of those amino acids. Insulin is actually two chains, so two peptides held together by sulfur-sulfur bonds between cysteine amino acids. There's an alpha chain and a beta chain, and in total there are 51 amino acids which make up insulin. Now, if you want to do an interesting parlor trick at a cocktail party, you can memorize the sequence of those amino acids in insulin or glucagon and impress your friends at your next party. But I guarantee you that I will never ask you a question on what is the sequence of amino acids in either of these two compounds, but I do want you to understand that they are protein hormones that come from the pancreas. Anabolic, stores and builds. Catabolic, breaks down for energy. So insulin is an anabolic hormone because it pushes glucose into the cells, which we will then store as glycogen. Catabolic, glucagon will break down glycogen so that we can release insulin, so that we can release glucose and then utilize that glucose as an energy substrate. So insulin's our anabolic hormone and glucagon is our catabolic hormone. Insulin is synthesized in the pancreas, and it's actually synthesized as an inactive compound. So when we make insulin in the pancreas, it is one long peptide or one long chain of amino acids, and then that chain is cleaved at two sites, and you can see where the blue arrows are. When that peptide gets cleaved, the protein that comes off is referred to as C-peptide. And then what's left then are these two chains, the alpha chain and the beta chain, hooked together by those sulfur-sulfur bonds on the cysteine amino acids, and that is active insulin, okay? So we make it as an inactive form referred to as pre-proinsulin, and then when we need it, we cleave off that C-peptide and release insulin as the active compound. We will talk more about the action of insulin, but take a look at page 705, table 21.7, and that will begin to show you the vast number of physiologic processes which are initiated by insulin. So it's more than just moving glucose into cells. Insulin has a number of effects. Take a look at table 21.7 to see what all those different effects are. All right, so we said about 9.5%, 10% of the U.S. population has diabetes mellitus. Diabetes mellitus is further subclassified into a number of different types. And there's really only two of them that we're going to talk about in this lecture. We're going to talk about type 1 and type 2 diabetes. We'll talk a little bit about pre-diabetes, other more rare, less common forms of diabetes, such as gestational diabetes, something called MODY. We're going to leave that alone and not talk about that. Let's focus on type 1 and type 2. What's the difference? Type 1, you have no insulin. Pancreas is not producing any insulin at all. Type 2, we have insulin, but the body is either resistant to the effects of the insulin or the body cannot pump out enough insulin for the demand. Most children and young adults are going to have type 1 diabetes. In fact, type 1 diabetes is almost always diagnosed prior to the age of 30. About 10% of people with diabetes mellitus have type 1 diabetes, okay? Type 1 diabetes mellitus is an autoimmune disease. An inflammatory process destroys the beta islet cells of the pancreas. And as you recall, those beta islet cells are responsible for insulin synthesis and release. So if you destroy those beta islet cells, you have no insulin, and therefore you are dependent on an exogenous or an external source of insulin for the rest of your life. In type 2 diabetes, there's not an autoimmune process. We're really not destroying the pancreas in a way that happens with type 1, but we have underperformance of our insulin. And again, it's either that insulin's not working, we refer to that as insulin resistance, or we're not putting out enough insulin for the demand. This is the most common form of diabetes mellitus, diagnosed after the age of 40. We are, however, seeing an increasing pediatric population being diagnosed with type 2 diabetes mellitus. Your body mass index, your weight, and your diet are the primary risk factors for developing type 2 diabetes. The more overweight you are, the more carbohydrate you have in your diet, and the less active you are in terms of physical activity, the greater is your risk of developing type 2 diabetes mellitus. Prediabetes, as we will define shortly here, is a state of hyperglycemia that has just not quite yet met the criteria for diabetes mellitus, but if you were to stay on that path, you would likely go on to develop the full disease diabetes mellitus. Prediabetes is something that we talk about more commonly with developing type 2, not type 1 diabetes. All right, quickly on pathogenesis. Type 1, we already said, was an autoimmune destruction of beta cells in the pancreas that is usually mediated by T cells. There are some autoantibodies that are generated, but it appears to be the T lymphocytes that play the major role in destroying the pancreas. There are other ways that we can destroy the pancreas: trauma, cancer, right? If we totally destroy our pancreas from another mechanism, that will lead to type 1 diabetes, but most people who have type 1 diabetes have it due to an autoimmune reaction where T cells are destroying the islet cells. There's some genetic susceptibility, so we can do genetic testing on individuals and find out that certain HLA, white blood cell alleles, have been associated with diabetes mellitus. We know that there are some environmental triggers that can begin that autoimmune process, most commonly viral infections. A number of peer-reviewed articles have looked at viruses such as Coxsackie and enterovirus and rubella virus, and shown that individuals who have recovered from these types of infections have gone on to develop type 1 diabetes. There's a number of other, I'm just going to say it, bullcrap in the literature that looks at other things as a cause of diabetes mellitus. None of this has really been peer-reviewed by science. It's been peer-reviewed by activism. You can see my cynicism coming out here. Milk, gluten-containing cereals, nitrates in well water. There's all kinds of things that have been implicated as causing diabetes mellitus in children, and I'm not aware of any peer-reviewed article that can really pinpoint that some of these other things are in fact cause of diabetes mellitus in children. Nonetheless, type 1 autoimmune diabetes mellitus is due to destruction of cells. That destruction is done in an inflammatory process, and T cells seem to be the mediators of that destruction. We can find some autoantibodies, so we can find antibodies against pre-pro insulin. We can find antibodies against other proteins within the beta islet cells, specifically a transporter protein that moves zinc into the pancreas, a transporter protein called zinc T8. Zinc plays a role in, we talk about insulin, we'll get into insulin a little bit more. We'll see where zinc incorporates into insulin. There's a transporter protein that brings that zinc into the beta islet cell. Individuals who have type 1 diabetes often develop an autoantibody against that transporter. In fact, now the FDA in 2004 released an approved test for differentiating type 1 diabetes. So if an individual has hyperglycemia and elevated hemoglobin A1C and they meet the criteria for diabetes mellitus, one can now do a blood test for this autoantibody ZNT8, and the presence of that autoantibody would then help confirm type 1 autoimmune diabetes mellitus as that individual's particular form of diabetes mellitus. The two links here are active. You should take a look at that. It's very quick. Just look at that. And in terms of a question, I think it would be appropriate for you to understand that if an individual has autoantibodies against that zinc transporter, then their form of diabetes mellitus would be consistent with the autoimmune form or type 1. So summarizing the pathogenesis of type 1 diabetes mellitus, individuals seem to have some genetic susceptibility. They seem to be exposed to some type of environmental trigger. The ones that have been proven are some of these viral infections, and that then begins the autoimmune destruction of the beta islet cells. Some texts refer to this as insulitis. Itis, again, being an inflammatory condition. This inflammatory condition is targeting beta islet cells, the site of insulin production, so they refer to that as insulitis. And it takes about 90% destruction of these islet cells before the individual becomes clinically aware or starts to manifest signs and symptoms. And the signs and symptoms of elevated blood glucose is polydipsia, drink a lot, polyuria, pee a lot, with glycosuria, sugar in the urine. Normal states should not have any sugar in the urine, so glucosuria is the presence of sugar in the urine. Polyphagia, eating a lot, losing weight, feeling tired, and again, elevated blood glucose. These are the primary clinical signs and symptoms of type 1 diabetes mellitus. Please review that on page 738 in that table. Type 2 diabetes mellitus, a little bit different, considered to be more of a failure of insulin to work or a failure of the beta islet cells to pump out enough insulin. It's not an absolute destruction of those islet cells as we see in type 1. So combine insulin resistance with the failure to put out enough insulin. This leads to a relative deficiency of insulin effect, and that lack of insulin effect is what causes type 2 diabetes. There are some genetic factors and there are some environmental factors. We're going to get into that in a minute here. What are the risk factors for type 2 diabetes mellitus? Again, type 2 is not autoimmune. Very important to understand that. All right. There is no better person to talk about as a model for type 2 diabetes mellitus than one of my favorite cartoon characters, that being Homer Simpson. Homer Simpson, dope Homer. He epitomizes the lifestyle and risk factors for type 2 diabetes mellitus. So, couple things. Genetics. You can't control your genetics, right? You get what your parents gave you. So, an immediate family history of type 2 diabetes mellitus raises your risk. Certain ethnic groups also have a higher risk of type 2 diabetes mellitus, particularly Black, Hispanic, and Native American. Clearly, type 2 diabetes goes across all races and all ethnicities. There are plenty of Caucasians with type 2 diabetes mellitus, but that risk seems to be a little higher in those three ethnicities right there: Black, Hispanic, and Native American. Age over 40. So as we hit middle age and get into later adult years, our risk of diabetes mellitus goes up. Obesity, huge risk factor. We'll see that this is not only based on your weight, but also based on your waist circumference. Physical inactivity, hypertension. If you have elevated blood triglyceride levels, TG standing for triglyceride. If you have low blood high density lipids, HDL. And we'll have a unit in cardiovascular where we talk about the lipids and we'll break all these different lipids down. But for now, we'll just state that too much triglyceride or not enough good cholesterol in the form of HDL, both of those are risk factors for type 2 diabetes. If you develop gestational diabetes during pregnancy, that increases your risk of type 2 later in life. We're not going to talk about gestational diabetes, so hopefully that will be covered in a women's health class that you should be taking in the future. Same with polycystic ovarian syndrome, another women's health topic. We'll leave that for those. Leave that for those two courses. Very, very important that you know the risk factors for type 2 diabetes, which are stated on the slide, and I'll give you a little bit more help by watching video 3, nice little animated video that will go through what those risk factors are for type 2 diabetes mellitus. So you know that in the final quiz, and you know that in the eventual unit exam that I'm going to have questions on that, testing your ability to recognize patients and recognize individuals who have elevated risk of developing type 2 diabetes mellitus. Wouldn't be doing my job if I didn't give you those questions, right? So, all right. Waist size. The more you weigh and the more abdominal fat you have, the greater is your waist size, the greater is your risk of type 2 diabetes. So let's take a look at this. We can look at your body mass index, which is a plot of height over weight, and you need to get a BMI chart to do that. So you take an individual's height, and then you take their weight, and then you plot that out on a BMI chart, and you get their body mass index. You're considered overweight if your body mass index is over 25. You're considered obese if it's over 30, and extreme obesity if over 40. And they rank obesity in 3 different classes based on your BMI, 30, 35, and 40. And then take a look at waist circumference. Men with a waist circumference greater than 40 inches and women with a waist circumference greater than 35 inches also increases your risk of type 2 diabetes. So if you're a male with a waist greater than 40 inches and a BMI of, let's say, 37, you can see that you have a very high risk. If you're a female with a waist of 36 inches and a BMI of 31, you would see that that would also plot you in a very high risk range. So don't memorize this. If I have any questions on BMI, and I'll provide you with the chart, but I do want you to be able to look at a chart like this and interpret it. So here you go. Why don't you try that? Let's suppose that your male patient is 5'10", weighs 245, and has a waist of 42 inches. And your female patient is 5'6", weighs 154, has a weight of 36 inches. Go to an online BMI chart, find what their BMI is, and then utilize that data and come up with what would you state is their risk of type 2 diabetes mellitus. And if I have you do this on an exam, I will provide the charts for you. It's important for you to be able to take the data and use the data, not memorize the data. Fair enough? Yes, it is, Dr. Stremski. Thank you. That is very fair. Okay, let's move on. All right, pre-diabetes mellitus. So that's that state where an individual has elevated blood glucose and elevated hemoglobin A1C, but they just have not quite yet met the diagnostic criteria of 6.5% for A1C, 126 for fasting, or 200 for random. See, I got that memorized. You can be able to memorize that as well. Seriously, I'm not cheating. I got that memorized in my head. So pre-diabetes mellitus, that means that you haven't quite hit those numbers, but they're outside of normal range. That places you at a higher state for developing type 2 diabetes mellitus. So a fasting glucose between 100 and 125, a hemoglobin A1C between 5.7 and 6.4%, pre-diabetes mellitus. And the Center for Disease Control estimates that almost coming close to 80 million people in the U.S. right now are in this state of pre-diabetes. Identify that early, mitigate their risk, and we can prevent these individuals from going on to developing full-blown diabetes mellitus. But be careful, even pre-diabetes mellitus carries some risk. And there are some studies that are out there that shows that your risk can be as high as 50% greater between normal glucose and A1C levels and pre-diabetic glucose and A1C levels. So that's the wake-up call. That's the hit in the head. That's the Homer Simpson, let's start doing something about this now before we go on to full-blown type 2 diabetes mellitus. Another slide that's just looking at risk factors again, okay? So again, we make that diagnosis of diabetes mellitus based on the blood glucose and A1C level. Any adult patient with a BMI over 25 should be screened. It's part of primary care. I would even say we're getting to the point now that we even need to start thinking about this in kids and teenagers. So take a look again at the risk factors. Elevated BMI, physical inactivity, first-degree relative with diabetes, high-risk race and ethnicities, Black, Hispanic, Native American, a couple other listed in there. Gestational diabetes, hypertension, low HDL, elevated triglyceride, polycystic ovarian syndrome, couple other things in here, other clinical conditions that have been associated with it. Again, important. Be aware of what are those risk factors for type 2 diabetes. And then, if you're brave, see the link there, diabetes.org. Are you at risk? Diabetes risk test. Take the test. Okay? Take the test. Be honest. Put in your own data there and see what you come up with. All right, let's see. We have to treat type 1 diabetes mellitus with insulin. We can treat type 2 diabetes mellitus with a whole variety of different drugs. But the most important part of treating individuals with prediabetes or the full-blown type 2 diabetes is lifestyle changes. A consistent carbohydrate intake, not a binging carbohydrate intake. Decreasing fat and calorie content in the diet. Doing some moderate weight loss. Key there being moderate. We don't need to have these individuals go fasting. Moderate weight loss. Space your meals out. Don't binge eat. And start some physical activity. And again, we're not asking people to become marathon runners. We're asking people to do a moderate level of physical activity, 20 minutes a day, 5 times a week. And I think as healthcare providers, that should be something that you should be participating in for yourselves anyway. Make that easier for you to counsel those individuals that you're going to see in the clinics and urgent care centers and wherever else you might be practicing to get physical activity as part of their lifestyle. Extremely important. All right, and then this slide again to review the pathophysiology of diabetes mellitus. Please be aware of the difference between type 1, beta cell destruction, autoimmune process, dependent on insulin for the rest of your life. Type 2, insulin resistance and relative deficiency, not pumping out enough insulin for the demand. Numbers of risk factors that we've looked at can lead to an increased risk of developing type 2 diabetes. Type 2 diabetes mellitus, which persists in a non-compliant individual or in a very severe case, can eventually lead to complete beta cell failure. And as I stated before, there are somewhere between 20 and 30% of individuals with type 2 diabetes that do eventually go on to require exogenous or external insulin supplementation. All right, here comes the molecular biology, and we'll try to be quick with it. We need to get glucose into a cell. We looked at the structure of glucose. We said that glucose is very polar due to those hydroxyl groups on it. And we said that the cell membrane, or you should know this, the cell membrane or the outer coat of the cell is very much a lipid. So it's tough to get polar glucose through that lipid membrane. We need to have some way of doing it. So we have a transporter protein referred to as GLUT4, G-L-U-T-4. See it there in the middle of the slide. That GLUT4 transporter lives in the cytoplasm, does us no good in the cytoplasm. So it's built in the cytoplasm, but we got to move it out to the cell membrane because on the cell membrane, glucose can move through that GLUT4, GLUT4 pore, if you will, or transporter and get into the cell. And then it can be used in the cellular processes for burning energy, right? We can either burn it for metabolism or we can store it, but we got to get it in the cell first. So how does insulin do that? Insulin is a protein. On the cell membrane, there is a receptor. When insulin binds on its insulin receptor, it goes through a number of cell signaling processes. that will result in the movement of that GLUT4 protein to the cell membrane. And then once GLUT4 is on the cell membrane, glucose can move in. The liver, fat cells, and muscle cells require insulin and GLUT4 excuse me, to get insulin into the cell. Not every cell requires insulin. We'll look at that in a second. But if we're talking about liver, fat, or muscle, we need to have insulin move that GLUT4 transporter to the cell membrane so that glucose can come in. All right? Video 4, it's kind of a cool video. It goes into a lot of molecular biology. I don't need you to memorize the molecular biology, but just look at how complex that is. We say insulin binds a receptor and it moves GLUT4 to the cell membrane. There's a lot of things that happen in between there. A lot of stuff that's being looked at as potential targets for diabetes treatment, etc. So the molecular biology is important, but we're training to be nurse practitioners, not molecular biologists, but I do want you to understand that there's a lot of stuff that's going on to make these physiologic processes work. So I do think it's worth your time to look at that 5 or 6 minute video and then say to yourself, man, I'm happy I didn't get it, that I didn't go the route of a PhD molecular biologist. Thank you. I'll work in my clinics and take care of patients rather than, writing grants to do molecular biology research. But God bless those PhDs coming up with that stuff, because it's that type of research that eventually finds its way to the bedside for development of new drugs and new therapies. So I think it's worth you spending a couple minutes to take a look at that. All right. Type 1 diabetes, there's no insulin, right? In type 2 diabetes, there's a failure of insulin response. So one of the ways that insulin may not respond very well in type 2 is an inability to make that movement of GLUT4 through the cell membrane and movement of glucose through GLUT4 to make that efficient. Okay, so you can see where type 1 fits here and where type 2 fits there. This is the same thing, just shown a different way. You can see glucose on the outside of the cell, the insulin receptor on the cell membrane, the GLUT4 transporter protein in the cytoplasm. Picture B shows insulin binding to the receptor, moves that GLUT4 transporter to the cell membrane, and now the glucose molecules are able to come into the cell. So again, insulin resistance is you just don't get that working well, right? You have insulin, but this whole process of being able to move glucose into the cell for whatever reason is dysfunctional. And that is a huge part of type 2 diabetes mellitus. There's I believe 1 or 2 paragraphs on page 739 that talk about insulin resistance. So be sure that you take a look at those 2 paragraphs. Just give you a little bit better handle on this concept of insulin resistance. There are a number of different types of glucose transporters in the body. They're called GLUT. They start GLUT. They go 1 through 5. Let's just talk about numbers 2 and 4. So we talked about number 4. Number 4 is important in getting glucose into the cell. Number 2, GLUT2 is important in terms of getting insulin to release. So let's look at this really quickly here. There's a cell in this graphic, and in that cell, inside that cell, we have a vesicle that's loaded with insulin, and we got to get that insulin out. How do we do that? So that cell is the beta islet cell, right? Because only beta islet cells make and store insulin. So after we eat and blood sugar rises, we get hyperglycemic, glucose can move directly into a beta islet cell through the number 2 transporter, GLUT2. See it? Doesn't need insulin. Remember, with GLUT4, GLUT4, you need insulin. But in this case now in the beta islet cell, we can just get the insulin directly into the glucose directly into the cell. Glucose gets into the cell. Glucose will then be metabolized As you recall, the metabolism of glucose will generate ATP, and it's the generation of ATP that allows the cell to pull calcium in, and then when calcium is pulled into the cell, that will be the stimulus to release the insulin. So we get elevated blood sugar, that sugar gets into the beta islet cell, the beta islet cell then releases insulin. Stuff in the middle gets a little bit complex, right? So between moving glucose into the cell and releasing insulin, there's some things that happen with potassium, there's some things that happen with ATP, there's some things that happen with calcium. When you get into pharmacology, that will become a little bit more important. I'll explain some of that in a slide or two here, but for now, I think the important part of this slide is to understand that in a beta islet cell, glucose can move in, and when glucose moves into that beta islet cell, that initiates the stimulus of these ion channels to eventually result in the release of insulin. Okay? Video 5 is a cool video. It's a molecular biology video, and again, I'm not asking you to memorize molecular biology, but I do want you to understand its existence and that it's there. And it is only by understanding molecular biology that smart individuals, smart PhD individuals, and other basic science researchers can develop drugs to implement in these processes. So we'll talk a little bit about the drugs as we move down through this. All right, GLUT2, GLUT4. The differences between those two transporters is important. All right, so back to some clinical stuff. Type 1 and type 2. Both type 1 and type 2 both lead to hyperglycemia. Why do we care about excess sugar in the blood? We're going to answer that question in a slide or two. But what are the symptoms of hyperglycemia? We talked about that already. Polyuria, glucosuria, polyphagia. So always thirsty, peeing more frequently. When you pee, there's sugar in that urine. There shouldn't be. Dry skin, always eating. Lethargy, feeling tired, blurred vision. And in some cases, injuries and infections tend to heal slower than what they should. These are the early clinical signs and symptoms of diabetes mellitus. Remember, diabetes mellitus is a vascular disease. What initiates the vascular pathology? It's something called an AGE, an advanced glycation end product. This one came out of sequence. Well, maybe not. Let's see. We're talking about hyperglycemia as being a bad thing. I also want you to understand that hypoglycemia is equally bad. In fact, hypoglycemia, blood glucose levels under 60, can be very devastating. Major reason for that is the brain can only utilize glucose. When blood glucose levels drop, the brain is deprived of necessary substrate. And when the brain is deprived of substrate, bad things can happen. Mental status and level of consciousness can change, and eventually the individual can develop seizures and coma. So take a look at the test tube there, and you can see we talk about plasma glucose levels in terms of milligrams per deciliter, so we're working with the bigger numbers on the right side of the tube. Remember, normal glucose levels are typically between, say, 60 and 110, right? The further down we get from 60, the greater is the incidence of having bad things happen, initially feeling tired, altered mental status, lethargy, difficult to arouse, and eventually that can lead to seizures and coma. So hypoglycemia is very, very, very much problematic. I'm not going to talk much more about hypoglycemia than be able to recognize that blood glucose does bad things to the brain. Remember the glucose transporter proteins? We need a transporter protein to get glucose into the brain, to get glucose into those neurons, But that transporter protein is very similar to the GLUT2 transporter, meaning it doesn't need insulin. So as long as glucose is there, we can get it into the brain. We don't need insulin to get glucose into the brain, so we consider the central nervous system transporter protein as being non-insulin dependent, right? There I said advanced glycation and talked to a couple people that I know in chemistry department where I'm teaching, and what's the right term? Glycation, glycosylation, I guess we can say both. But an AGE, it's sugar reacting with amino acids, and then these compounds such as CML, these compounds such as pentosodine, as they build up in the vascular wall, begins that process of inflammation and begins and contributes to the atherosclerotic plaquing. Our book talks a little bit about this. I think they only devote about one paragraph to it, and they talk about hexosamine as one of these AGA products, but again, understand there's a lot of them. Now, I know that there's probably some people in the audience that are really into molecular biology, so if you are, there's a great article right there from the American Journal of Renal Physiology, and you can knock yourselves out reading about these AGEs and how they form in the same way that you can knock yourself out memorizing the amino acid sequence of insulin. But trust me, these are not things that I'm going to test you on. Just the general concept of what started the vascular pathology in the first place. I kind of want you to understand that. Again, AGEs, advanced glycation end products. Sugar binds to the proteins. On proteins and cell membranes, it's going to induce inflammatory reactions on blood vessels, and that inflammatory reaction is going to be pathogenic to the big macro vessels and the small micro vessels. So hemoglobin A1C is actually an advanced glycation product. You know what hemoglobin is, right? I think next week we're going to get into hematology, so we're going to talk more about red blood cells and hemoglobin. Hemoglobin is the protein inside a red blood cell that carries oxygen. Red blood cells and hemoglobin are found inside blood. So if you have a bunch of glucose in blood, that glucose will bind the hemoglobin and creates a glycosylated or sugary hemoglobin that we call hemoglobin A1C. Hemoglobin A1C in and of itself is not pathologic. The red blood still works just fine with that hemoglobin A1C, and that hemoglobin A1C can bind oxygen. Hemoglobin A1C is just normal hemoglobin with glucose stuck onto it, and we call that hemoglobin. And so we call that hemoglobin A1C, and we can measure that in blood, and we can use that as a diagnostic marker for diabetes mellitus. So an individual that has persistently elevated blood glucose levels will develop more hemoglobin A1C. So we use hemoglobin A1C to help us diagnose diabetes mellitus, and then we can use hemoglobin A1C to help us decide, is our patient being compliant with therapy? Because let's say that we saw him in July with a hemoglobin A1C of 8.5%, then we say, you've got diabetes mellitus, and we do some further investigation. We say, you've got type 2 diabetes mellitus. And now we tell our patient, you need to change your diet, change your lifestyle, change your physical activity. Maybe we'll start you on one of these type 2 diabetes mellitus drugs. I want you to come back and see me again in October, and you do a hemoglobin A1C level, and now the level has gone from 8.5% to 9.6%. Then you have a fit, right? Because your patient is not being compliant with treatment. One would expect with proper treatment and compliant treatment that A1C level should have dropped. In fact, it's a goal. The American Diabetic Association states that our goal of treating diabetic patients, both type 1 and type 2, our goal is to get them down to a level of 7%. Okay? So hemoglobin A1C, a very important diagnostic a marker. We'll have more to say about that as we move on here. We can use a hemoglobin A1C to estimate what our patient's average blood glucose level is, right? So remember the kid I told you about that I saw last night in the emergency department? For those of you that remember the story, remember what his presenting hemoglobin A1C level was? Higher. No, it was 14%, right? He said his presenting hemoglobin A1C level was 14%. And do you remember what I said his blood sugar was when we saw him in the emergency department? I may have said 608. It was 508. Okay, so he had a blood glucose level of 508, very high, probably walking around like that for a number of weeks. And that's what led to his very high hemoglobin A1C level. So as that young adolescent is put on, so he's probably going to be type 1 diabetic, meaning he's going to need insulin. So as he gets started on insulin and his blood glucose levels fall, we then subsequently expect his hemoglobin A1C level to fall as well. And again, goal of therapy, try to get them down to a 7%, because if we can get them down to 7%, then we know that over time their blood glucose levels are minimally elevated as opposed to profoundly elevated. We don't want our patients walking around with blood glucose levels persistently greater than 180 and certainly not greater than 200s, right? So our A1C is a nice marker for that. All right. We talked a lot about the difference between type 1 and type 2. You understand the pathophysiology, how we make that diagnosis. The next big important point is to understand that the damage done due to diabetes mellitus is the same whether you're type 1 or type 2. All right? So it doesn't matter what type of diabetes mellitus you have. If left to go on, if left to worsen, particularly in a non-compliant patient, the pathology that occurs at the end organs will be the same. And the big pathologies that we see are in the eyes, particularly in the retina and the lens, in the kidneys, on the coronary arteries, on the peripheral arteries, on the cerebral arteries, on the neurons, on the nerves, and in tissue with respect to infection. So retinal hemorrhage and going blind, cataracts and going blind, damaging your kidneys and ending up on dialysis, developing cardiomyopathy, myocardial ischemia, and heart attack, developing ulcers in the extremities, erectile dysfunction, diabetic nerve pain, and again, breakdown of skin which results in increased risk of skin infection, which can lead to sepsis. Whether you're type 1 diabetic or type 2 diabetic, type 1 or type 2, those end results are going to be the same. Now, we have not talked about the kidneys yet. We have not talked about the heart. We have not talked about the brain and neurons. We haven't had a whole lot yet on, we had a little bit of stuff on infection as it relates to skin. So we'll get there, okay? And as we talk about the heart and the brain, we'll come back and we'll talk about the specifics of diabetes resulting in nephropathy and cardiomyopathy, etc. For now, what I want you to understand is both type 1 and type 2 diabetes can result in all these adverse effects, and we'll get more deeper into the pathology as we get into the specific units, okay? Retinopathy, damage to the retina. Nephropathy, damage to the kidney. Cardiomyopathy, damage to the heart. Neuropathy, damage to neurons. And then again, skin and tissue breakdown leading to increased risk of infection and sepsis. So let's take a time out here for a second and summarize. How is diabetes mellitus diagnosed? First, we get a clinical suspicion. What are those signs and symptoms that make us worrisome for hyperglycemia? We talked about that, polydipsia, polyuria. We have an individual then who we're suspicious, so we will look for sugar in their urine. We will do a blood glucose level, and we will do a hemoglobin A1C. And again, now you're starting to commit to memory that an A1C greater than 6.5%, a fasting blood glucose greater than 126 milligrams per deciliter, a random blood glucose greater than 200 milligrams per deciliter gives us our diagnosis of diabetes mellitus. Then what we need to do is we need to determine is it type 1 or type 2. We can look at age of presentation. Children and young adults more likely to be type 1, but again, we are seeing increasing incidence of type 2 in kids. What do you think's leading to that? You think that bad diets and sedentary lifestyle and overweight kids that don't like to go out and exercise but sit and watch TV and eat Cheetos and play video games, think that's playing a role in increasing incidence of type 2 diabetes in kids? Yeah. So age of onset could be tricky. Clinical presentation, be familiar with how those two cases come out, right? Type 1 diabetic is more likely to be losing weight. Type 2 diabetic is more likely to be overweight and gaining weight. And then we can look at some labs. Let's look at the difference between type 1 and type 2. If we assayed somebody for insulin in their blood, who does not have any insulin in their blood, the type 1 or the type 2? The type 1, right? No insulin. And if we looked at presence of autoantibody, particularly now this newer antibody, ZNT8, who has that, the type 1 or the type 2? Very good, the type 1, right? So no insulin, presence of autoantibody, a laboratory way of coming up with, is this type 1 or is this type 2 diabetes mellitus? Pretty cool, right? All right, time for you to get on Blackboard, and you need to all list the specific diagnostic criteria for diabetes mellitus. And when I'm talking about specific diagnostic criteria, I'm talking about blood glucose and hemoglobin A1C, right? I want you to commit that to memory. So go ahead, list that on Blackboard. All right, we're an hour and 12 minutes into this. Hopefully we can wrap this up in the next 30. Let's talk a little bit about pharmacology, and let's start off by talking with insulin here. Very long time ago, but we don't even really need to go back that far. We can go back to the 1910s, 20s, and 30s. Diabetes mellitus was really a death sentence. Particularly type 1 diabetes mellitus really was a death sentence because we did not have any real good way of getting insulin back into individuals. And what used to be done, this sounds gross, but what used to be done was just getting the pancreases from the slaughterhouses of cows and pigs and grinding that pancreas up and having individuals literally inject themselves with extracts of animal tissue. And it did work, but as you can imagine, it's only going to work for a short period of time. That's foreign material. There's going to be an immune response generated to that. That's certainly not sterile. Individuals are going to develop skin infections and abscesses. So it worked for a while, injecting people with the tissue, but eventually what had to happen was they had to be able to extract the insulin, purify the insulin, and make that more of a sterile process. So even to the mid-1980s, we were treating type 1 diabetic patients with pig insulin and cow insulin. And it wasn't until the mid-1980s that we first began to see synthetic human insulin being made. Now, we were never at a point in our history where we were farming humans for their pancreases to extract insulin, right? That would kind of make for a kind of a creepy science fiction type book, right? Some evil corporation, capturing humans and, growing them just for their pancreases to get human insulin. We didn't do that, right? We're going to have to talk about how did we make human insulin. We didn't farm human insulin. But before making human insulin, we were initially injecting people with extracts of pancreas, and then eventually extracts of purified and sterile animal insulin products. So there we're probably looking at, I don't know, cow guts. Can you tell? You should be able to tell where the liver is, right? You can see some of the intestine. You see the pancreas kind of in the pancreas is in that, see that loop of intestine on the left side? See how that intestine loops, and then in the middle there looks like a more of a solid organ in there. That's probably cow pancreas right there. So imagine that, being ground up and injected to you back in the 1930s if you had diabetes mellitus. Pretty brutal, right? All right, so we have gone, so look at the far right now. We've gone from an animal extract to a purified animal insulin to a human insulin, and now we have a number of analogs of human insulin. We'll talk about what that means in a second. So there's the insulin molecule again, and for those of you that spent some time memorizing the sequence, I hope you didn't do that, but maybe some of you guys did that, right? There's the A chain and the B chain, and you can see what the amino acid sequence is. Now look at the A chain at positions 8, 9, and 10, and look at the B chain in position 30, and then look at pork, beef, and human, and you can see that other than those positions right there, the amino acid sequence is pretty much the same. The structure between between cow insulin, pig insulin, and human insulin is very similar with the exception of a few amino acids. You should understand it, but again, don't memorize it, right? Unless you want to look fun at a cocktail party and you can tell somebody the difference between cow and human insulin. That's great, but it's not something I'm going to test you on, all right? But look at it, and this kind of tells you why medical science was able to do that, why we were able to treat children and young adults and adults with cow insulin and pork insulin, because the structural similarity between the three different species. But we don't do that anymore. We use human. Not only do we use human insulin, but we use analogs or variations of the human insulin. How is that done? Well, insulin is a protein. All proteins come from a gene on DNA, so therefore there's a human gene for insulin. If we can take that human gene and put that human gene into a microorganism, we can teach that microorganism how to make human insulin, and then we can extract that human insulin from the microorganism. And we can even change the gene around a bit so that we get human insulin, but with a little bit of different amino acids on it. And that's what the analogs are. So we have human insulin, which is the natural sequence, and then we have analogs, which is the natural sequence which has been adjusted just a little bit, maybe by one amino acid, maybe by two amino acids, and those are the analogs. So we look at things at insulin Lispro, insulin aspart, insulin glargine, and something else called insulin dedamer. That's human insulin, but in an analog form. It's a little bit different. Lispro, we substituted proline for lysine. Aspart was the substitution of aspartamine. Glargine is the substitution of two arginine molecules. So look at the insulin sequence, and then you can see in the spheres how that's a little bit different. And again, you don't need to commit that to memory. When you get into pharmacology class, they might ask you to understand that a little bit more. I'm just doing this as an introduction here for you to understand how we've gone from animal insulin to human insulin and now human insulin analogs. And what's important about that is as you change the amino acid structure, you can change the kinetics. So now you can make insulin work really fast for a short period of time, or you can make insulin last for a long time, for a whole 24 hours, but act very, very slowly. And by doing that, remember all the way back to the beginning of this lecture, we talked about how the pancreas releases insulin in both basal and bolus effect. Now we can have insulin analogs that act like a bolus, and we can have insulin analogs that act like a basal, right? So dedamer insulin, an insulin that has a long fatty acid attached to it, so you can see dedamer there in the gray, and glarginine insulin, or Lantus, trade name Lantus, has the two arginine molecules at the end. Those two are long-acting insulins. We can give it once a day, and we get a basal function out of it. Lispro and Aspart, Humalog and Novolog, by trade name, are analogs. They act very, very quick. So if we're going to have a big meal, if I'm a type 1 diabetic and I'm going to have a big meal and I know I'm going to need insulin, I can inject myself with the rapid-acting analog, have my big meal, and now that insulin is there to help me out process that carbohydrate as that carbohydrate is ingested and absorbed into the bloodstream. So that's what we're talking about with the human insulin analogs. And here they are. So we've got Humalog, Novolin, Apidra. Those are rapid-acting human insulin analogs. They start within 30 minutes and last for about 2 hours. We have an intermediate-acting analog referred to as NPH. So that acts somewhere between 4 and 12 hours. And then we have some long-acting insulins that can last as long as 12 hours. Lantus, that's the glargine. Levemir, that's dedamer. And then the newest one on the market is this pen one called Toujeo. Toujeo is glargine. Toujeo and Lantus are essentially the same analog. They're just packaged a little bit different in that the Toujeo product is packaged in a pen, but they're both the same glargine analog. So video 6 is really cool. I love video 6. It's something that a middle school kid could possibly understand. It comes from the show How Do They Do It, or How Do They Make It? And they just show you very basically how is it that scientists have been able to take the human gene for DNA, put it into a microorganism, in this case yeast organisms, and grow these yeast organisms in vats and go through this process of extracting out that purified insulin and getting that purified insulin out in solution, crystallizing it into powder, and then resolubilizing it so we can get it into vials and to get it into pens. It's extremely interesting. Get your kids, if you have them, and sit down and watch that 6-minute video in terms of, and just think of how much research and how much dedication it took to be able to get to that point that now we have these products like Lantus and Toujeo and some of these really, really interesting analogs that are out there. And you would agree with me, we've come a long way from injecting people with the crude extract of a pig pancreas to something like Toujeo or Novolog. So the pharmaceutical insulins, or the analogs, are characterized based on how long duration of activity we have. We have rapid acting, 30 minutes to 2 hours, intermediate acting, 4 to 12 hours, and long acting, 12 to 24 hours. Our basal insulins are the long acting ones. Our rapid acting analogs are our bolus ones. Here's Levemir. Dedamer is another name for it, and what they've done with Levemir is you've got that sequence of amino acids. There's a lysine at the end, and then you have a big fatty acid attached to it, and that big fatty acid allows it to have better binding onto albumin, better binding into fat, so it acts as a long-acting insulin. 3 different ways that we can give insulin. Conventional insulin is you get 2 shots per day of an NPH and a rapid-acting analog mixed in one. The intensive regimen is you get 1 shot a day of a basal and then up to 4 shots a day of a rapid-acting, depending on when you eat your meal or your snack. And now, more frequently now, using a pump, which is a continuous infusion of a rapid acting, and then what the individual do is they will adjust their pump to give them a bolus of the insulin based on when they eat. So this is pharmacology and pharmacotherapy. I'm just kind of getting you ready for that, wetting your whistle a little bit, if you will, for when you have the pharmacy people come in the pharmacology, pharmacotherapy classes and talk to you a little bit more about the detail of how this is done. Now at least you understand the differences in the insulins, what we're talking about, analogs, and just very briefly introducing you to the different types of regimens that are out there for insulin. And who needs it? Lifelong? Type 1 or type 2? Thank you. Type 1. Does a type 2 diabetic always need insulin? No, but depending on how fast their disease progresses, how compliant or non-compliant they might be with therapy, they very well might need insulin at some point in their life. Type 1's always going to need it lifelong. All right, now you know a little bit about insulin analogs. You know a little bit about insulin names. Go back to that slide that's got the analogs out there and pick 2 of these scenarios, and based on these scenarios, tell me what insulin product you would recommend. So we got somebody who just woke up, they're going to have breakfast. You've got somebody who is just on a twice a day maintenance control. You've got another individual who's just on a once a day 24-hour control. And then, hey, surprise, I'm type 1 diabetic and there's a surprise office party and I'm going to go have a piece of cake. Should that individual take some insulin? And if so, which one should they use? All right, so pick 2 of these and put your answers on Blackboard and let's see what we come up with. I think we should be able to generate a pretty good discussion with that. All right, back to Homer and type 2 diabetes. If you have type 2 diabetes, do you need to take insulin? Not necessarily, okay? Remember, we need insulin to get glucose into liver, fat, and muscle. We do not need glucose. We do not need insulin to get glucose into the brain, and we don't need glucose to get it into the heart either. So brain and heart's the exception. They can just take in glucose through non-insulin dependent means. But for the fat, muscle, and liver cells, we need insulin. A type 2 diabetic either doesn't have enough of it or has deficient functioning of the insulin, so there's a number of things that we can do. Again, the most important are non-pharmaceutical, physical activity, weight loss, dietary management. Go back to that slide, right? Space meals, don't binge eat, watch your carbohydrate load, 20 minutes a day, 5 times a week, right? Moderate weight loss, important. But then there's a whole number of pharmaceutical products that are out there that target different physiologic processes, and these physiologic processes then are areas where we can design drugs to help with hyperglycemia. So there's a thing called the ominous octet. It's also referred to as DeFronzo's octet, after Dr. Alan DeFronzo, who was one of the first individuals to describe this. The octet is found on page 740, and I'm going to show you here. Right? So here's the octet, and here's a lot of different ways that the body reacts to increase blood sugar, right? Insulin and glucagon are very important, but there's other processes that go on to either raise or lower blood sugar. And these are all things that we can hit with respect to a drug where we can either improve the release of insulin in a type 2 patient, or we can improve the function of insulin in a type 2 patient whose problem might be more insulin resistance as opposed to lack of insulin. So we have drugs that can allow you to secrete more insulin, impair glucagon secretion, alter how much glucose you absorb from your gut, alter how much fat you break down, alter how much glucose your kidney reabsorbs, alter how much glucose your skeletal muscle utilizes. So without getting into too much pharmacology, just let me show you a couple of drug classes that are used for treating individuals with type 2 diabetes mellitus, and it's all based on this ominous octet. What are the different physiologic processes that can lead to hyperglycemia. Right? So here's the octet in words, tells you what is it about the different areas that raises your blood glucose. I'm going to talk about 4 of these by the star here. I'm going to talk about increasing insulin release, right? So a type 2 diabetic patient still can make insulin. So maybe we can increase their insulin release. Let's talk about how we can block their glucagon release. We can talk about how we can block glucose production by the liver, and then we can talk about how we can force the kidney to pee glucose out. Because if you pee your glucose out into the toilet, that might be one way of lowering your blood glucose level, and that now has become an important means of managing type 2 diabetes. So let's look at these 4 drug classes quickly here. Here are the sulfonylurea drugs. The sulfonylurea drugs allow you to secrete more insulin. This will never work in a type 1 diabetic patient. Oh, geez, I just gave the answer away. All right, forget it. Hold on. The sulfonylurea drugs act on the beta cell, act on one of these potassium ion channels, and by inhibiting that potassium ion channel, what we get is we get more release of insulin. So we're forcing the type 2 diabetic patient to release more insulin, okay? Glyburide and glipizide, so diabeta, a trade name, glucotrol, a trade name, that's what these drugs do. Over time, you can burn your pancreas out, right? So these are good for a while. And there was a point where these were the only drugs available for type 2 diabetes. So they work, they help the person release more insulin, but they can result in beta islet cell burnout. Okay, now I gave the answer away, but think about it. Can you treat type 1 diabetic patients with this drug class? Why or why not? Post your answer on Blackboard. I kind of gave it away, but think about that. Very important point. Can you use this drug class in type 1 or not? Glucagon, remember, is the hormone that raises blood glucose. So one way that we can lower blood glucose is by using something which is an antagonist to glucagon. And this is what these drugs are. They're called GLP-1, glucagon-like peptides. These glucagon-like peptides are also referred to as incretins. And one of the mechanisms of an incretin is to inhibit glucagon activity. And by inhibiting glucagon activity, you can lower blood sugar. These are proteins, so like insulin, they have to be injected. You can't give it as a pill. So Byetta and Victoza, some of you guys that are already working in internal medicine and family practice, you've probably seen these drugs. These are protein hormone drugs, GLP-1 or incretins. Our body makes these things. So these are natural hormones that antagonize the effect of glucagon, but now we have synthetic incretins that we can inject into type 1 and to type 2 diabetic patients to impair glucagon secretion. All right? So there's another class. Byetta and Victoza are probably the 2 most common ones on the market right now. They're not cheap, folks. They are not cheap. Get your patients to exercise and lose some weight and eat appropriately, and maybe they don't need to spend $500 to $1,000 a month injecting themselves with Byetta or Victoza. Okay, off my soapbox. Metformin. Some of you have probably heard of metformin. Metformin has some very complex mechanisms of action, but what metformin can do is it can decrease, by inhibiting certain enzymes in the liver, it will decrease how much glucose the liver will make. This is a really nice drug in that it enhances glucose uptake, so it works a little bit on that insulin resistance that we've talked about. And people on metformin will burn some fat, and that allows for them to lose some weight. And weight loss is an extremely important part of managing a type 2 diabetic patient. So many, many individuals that you see with type 2 diabetes will be placed on metformin. In fact, metformin is considered to be one of the first line drug treatments for type 2 diabetes. It has a couple different mechanisms of action which are very useful for type 2 diabetes. And now these are the new ones, Invokana and Farxiga. I have a hard time saying their generic names, canagliflozin, dapagliflozin, right? What do these drugs do? These drugs help the kidney pee out sugar. So remember, a diabetic patient, they have elevated blood glucose. That blood with all that sugar in it gets presented to the kidney. And what will happen in diabetes is the kidney will have a hard time processing all that extra sugar, so that sugar ends up in the urine. Normally, we don't put any sugar in urine, right? But in diabetes, because you've got all this additional glucose in the blood, some of that ends up in urine. So one way that we can lower blood glucose is by forcing the kidney to pee out, to excrete out more sugar. How is that done? There's a transporter in the kidney tubule referred to as SGLT2. The role of that transporter is to take sugar out of the urine and bring it back into blood. We'll get more into kidney physiology. We do the renal unit. We'll come back to this class of drugs. It might make more sense then. But sugars in urine, normally we want to recover that sugar, right? And the way that we do it is through this transporter called SGLT2. If we gave a drug that inhibited SGLT2, all that sugar stays in the urine and out it goes into the toilet. So these drugs, Farxiga and Invokana, force the diabetic patient to pee out more sugar. They get a very, very high content of glucose in the urine. Quite honestly, it's like they're peeing maple syrup. No kidding. And you think of it, you're forcing the kidney to pee out glucose, and it gets to the point where the glucose content in the urine can get so high, it's like they're peeing maple syrup, right? Well, think about that. What might be a problem with having such high content in glucose in your urine? The answer is on the slide here. Do you see it? Yeah, infection. Who loves sugar? Microorganisms love sugar, right? Bacteria love sugar. Candida albicans, yeast love sugar. So urinary tract infections, yeast infections are going to be more common in people taking these drugs. And because they're peeing out more sugar, they tend to pee more. So that adds to that whole process of polyuria. So they work. They do help reduce blood sugar, but they come with a cost. And these drugs have not been out for the longest period of time. If you're paying attention to TV right now, you see these things being advertised. You also see the lawyers now talking about, hey, if you were on Farxiga and you experienced life-threatening urinary tract infection or whatever, call our law firm. So where these are going to fit in the scheme, in the overall scheme of managing type 2 diabetes is, I think, yet to be determined. I quite honestly, if I had type 2 diabetes mellitus, I don't know that that would take this drug. Just, what is that long-term hyperglucosuria going to do to your kidneys? I don't know that that's been fully delineated. So again, a little bit more soapbox by me. I hate to do that, but again, I just like to throw in some of my thoughts now and then, particularly with drugs, because I am a pharmacologist by heart, and I love talking about these drugs. I find these SGLT2 inhibitor drugs very fascinating based on their mechanism, and even more fascinating based on the adverse effects that people are experiencing because of the fact that they're peeing maple syrup. All right, interesting stuff, right? So again, a lot of different drugs. So we have the octet. There's 8 different ways that we can approach hyperglycemia, and we got all kinds of different drugs in there. I talked a little bit about the sulfonylureas, the GLPs, the SGLT2 inhibitors, and MET metformin, but you can see there's other drugs that are in there. Pharmaceutical management of type 2 diabetes mellitus can get very complex, and we'll leave some more of the fine details to the good professors from the School of Pharmacy, the PharmDs there, to when you get them in your course. But now at least you've got a nice little background that you can work. Can't stress this enough. Non-pharmacologic medical therapy for type 2 diabetes. Eat a consistent carbohydrate intake. Don't binge on carbohydrate. Modify your fat and calorie content. Space your meals. Moderate weight loss. Physical activity. 20 minutes, 5 times a week. You don't need to be a marathon runner to treat type 2 diabetes, but you do need to start getting some physical activity into your life. All right, again, Homer Simpson. So what can go wrong with diabetes mellitus? Again, whether you're type 1 or whether you're type 2, it can affect almost every type of tissue, every organ system in the body, and the reason for that is due to the pathologic effect on blood vessels. So review that again in video 7. Video 7 tells you all the different things that can happen in terms of the vascular pathology, but understand that as we get into the different units, we'll talk in more detail about diabetic nephropathy, diabetic cardiomyopathy, etc. Just be aware that this is a multi-organ disease due to its pathologic effect on blood vessels. Here's where I want you to take a look at the Wisconsin Essential Care Guidelines, because in these guidelines, it's set up in a number of different sections. So you can look at the insulin section, the drug section, the clinical section. Really, really nice document to have. It's huge, but a lot of good things in there in terms of diabetic counseling, dietary counseling, everything that you need to help you counsel and manage a diabetic patient, particularly a type 2 diabetic patient. You're going to find this in this PDF file. There's the link directly to the website, but I have it posted for you on Blackboard. Keep that. At some point in your life, you will all use that. This comes directly out of the Essential Care Guidelines, and it shows you all the different, on the far left column, the different organ systems, the pathologies that can go wrong, and then what's their recommendations in terms of what do you look for as a clinician on the physical exam, and how often do you need to be screening for these problems. So retinal exams, dental exams, vascular exams, blood pressure, assessing renal function, assessing for neuropathy, sexual dysfunction, assessing men for erectile dysfunction, and even assessing women for sexual dysfunction. Sexual dysfunction, common problem with individuals with type 2 diabetes. Hey, trust me on this one, because I know people that take care of type 2 diabetic patients. Sometimes they have a hard time getting through to them, talking, hey, you're ruining your eyes, you're ruining your teeth, you got these ulcers on your feet that you can't, that won't heal, this is damaging to your kidney. It's not until they start showing sexual dysfunction do some of these people finally wake up, particularly males and erectile dysfunction. You talk to your blue in the face to a overweight 40-year-old male with type 2 diabetes of, why it's damaging his kidney or why he might end up, losing his vision in a couple of years, but start to experience erectile dysfunction and all of a sudden, oh, wow, time to be compliant and think about, what's happening in my life here. Use what you can, right? Everyone's going to respond to something different. The Wisconsin guidelines here, really nice at showing you the different parts of that physical exam that you really need to be concentrated on when you are evaluating these patients in a primary care clinic. And then again, whether you're type 1 or type 2, long-term hyperglycemia is going to lead to these irreversible vascular and connective tissue changes. We talked about retinopathy, cataracts. Hypertension is both a cause and an effect of diabetes. Hypertension can increase your risk of diabetes. Diabetes worsens your hypertension. It becomes a vicious circle. Renal failure, coronary artery disease, neuropathy, diabetic neuropathy, increased risk of infection, and again, erectile dysfunction. Erectile dysfunction in males, sexual dysfunction in both males and females, right? Type 1 versus type 2, different clinical presentations, different pathologies. If you have a bad diet and you are obese, it will make your type 1 and your type 2 diabetes worse. So it's important, even in your type 1 patients, to be talking about healthy diets, physical activity, and weight loss. But again, the long-term complications are going to be the same. Diabetes in the United States of America is the #1 cause of individuals needing dialysis, needing coronary artery bypass surgery, having toes, feet, and legs amputated, going into rehab because of a stroke, or going into rehab for some other type of neuropathic pathology. Boy, if you can't sell that to individuals in terms of why their diabetes mellitus is a bad thing to have and why they need to be compliant, it could be a hard thing. It could be a very, very hard thing trying to sell those patients in a primary care clinic reasons why they need to be compliant with the recommended treatments that you're setting forth for them with respect to diabetes, particularly the lifestyle changes. You got all kinds of drugs, and people would just love to take a drug and cure their problem, but they need to exercise, they need to change their diet, they need to take some weight off. Go to video 8, and you got some more stuff that you can watch there with respect to complications of diabetic neuropathy. You've seen that on television, right? I've had diabetes for so many years. My feet hurt, pins and needles. It feels like my toes are on fire, right? That's part of the neurologic damage being done. So if you're injuring blood vessels that are feeding peripheral nerves, you end up with this really bad sensory neuropathy. There's all kinds of drugs that are out there that treat the pain. So if you look at things like Lyrica and tapentadol and Cymbalta, these are drugs that are managing the individual's pain. It's not managing their diabetes, right? So they're taking Lyrica to control the pain that they have from neuropathy, but it's not doing them a whole lot of good if they're not managing their diabetes. I know, Stremski, more soapbox, but important to hear. Important to hear. Somebody's got diabetic neuropathy. You've got options to manage their pain and manage their symptoms, but those drugs don't manage their diabetes. They need to manage their diabetes. Finally, foot ulcers, right? And this is what leads to recurrent infections. This is what leads to gangrene. This is what leads to sepsis. And this is what leads to eventual amputation. Why? Remember, hyperglycemia leads to AGEs. AGEs causes vascular inflammation, enhances the process of atherosclerosis. When you have damaged blood vessels, you don't get good oxygenation of tissue. When you don't get good oxygenation of tissue, the tissue can't heal. So what becomes a small blister or a small ulcer on the bottom of the foot can progress to necrotizing fasciitis, cellulitis, and abscesses, which can lead to sepsis, and in a worst case scenario might mean that parts of the foot or the whole foot or even above need to come off because you can't control the infection. Give a little case vignette here for you. 47-year-old, 10 years of being a type 2 diabetic, very non-compliant, still smoking, hasn't been to your clinic in 18 months, comes in now with a temperature of 103, his feet hurt, his toes hurt. He had no idea there was an ulcer on the bottom of his foot because he wasn't doing the appropriate foot care that he should be doing, and then you take off his shoe and you see that. Wow, that's going to be tough, right? That's going to require intravenous antibiotics. It's going to require surgical debridement. Going to be very, very difficult to manage that type of ulcer on this non-compliant diabetic patient. Video 9. Hopefully you didn't eat lunch before watching video 9. Video 9 is a very graphic tour, if you will, of different types of foot and leg complications due to diabetes mellitus, with a particular focus on some very nasty looking ulcers. Retinopathy, leading cause of blindness in the U.S. Again, manage your diabetes appropriately and you can manage some of these complications. There's some very interesting drugs that have been developed, drugs that are referred to as VEGF, VEGF inhibitors, and these are small protein drugs that inhibit inflammatory response on the retina. The interesting things about these drugs is they have to be injected into the eye. Ouch, right? They have to be injected into the eye. And if you take a rotation in ophthalmology, you'll see more about that. They'll probably talk about that in the pharmacology class, talk about these newer VEGF inhibitors being used to treat diabetic neuropathy. But again, intraocular injection. That does not sound fun. Goals. You got your diabetic patient, you're coming up with a plan. What are we looking for? We're trying to get nice control of blood glucose. So the American Diabetes Association has set goals for A1C, for fasting glucose, and what's called postprandial glucose, or what's your blood glucose levels 2 hours after you eat. 7% for the A1C, 80 to 30 for a fasting, under 180 for a postprandial. This is kind of what we're shooting for in terms of managing diabetic patients, both type 1 and type 2, in terms of where do we want their blood glucose levels to be from the therapy that they're taking and the lifestyle changes that they've adopted. Because they're all going to adopt lifestyle changes if they're your patients, right? Seriously. Is it complex trying to come up with the drug therapy for type 2 diabetes? Yes, it is very much here. Again, just kind of wetting your whistle with this one. How do you decide on what drugs to use for type 2 diabetes? It kind of depends on how bad their A1C level is. So for a low A1C to a higher A1C, you can start with monotherapy, go to dual therapy, triple therapy, and then eventually if the individual's on triple pharmaceutical therapy and still not responding, then they might need to end up on insulin. All right. A lot of type 2 diabetic patients may not need that intensive basal bolus dosing that you see in a type 1 patient. Maybe all they need is a once a day basal. So this is where like drugs like Lantus and Toujeo have played a big role in the management of type 2 diabetes. It gives the individual, a lot of times all they need to do is inject the basal insulin and they use some of these other pharmaceutical therapies to help control with postprandial hyperglycemia. I'll let you go through that with the PharmD, with the good PharmD professors that you will have in your pharmacology course. But again, just kind of getting you ready for some of that. All right, Homer looks happy in this one because with proper management and lifestyle changes, the complications of diabetes mellitus can be avoided or reduced. So you can almost hear him now, right? Woohoo! That's Homer's, happy thing, Homer's happy dance. So if Homer becomes compliant with his nurse practitioner in the primary care clinic who is telling Homer what are the specific lifestyle changes that he needs to take into account, maybe Homer won't need to go on any of these drugs and maybe he will be able to slow or actually even reverse some of these pathologic processes. So your last thing for Blackboard is to imagine that you are counseling a patient with type 2 diabetes and list some of the lifestyle changes that you want your patient with type 2 diabetes to adopt. This should be another good discussion that we can have on Blackboard. 1 hour, 54 minutes. What do you think, class? That's pretty good, right? I've been at the 2 hour and 15 point. And you think one even went to 2:20. So 154 and change. That's good for me. What do you think? Good topic? Important topic? Hopefully I convinced you why we needed to do 1 week just on diabetes mellitus. So just like every other week, once you've gone through this presentation, read the assigned pages and particularly pay attention to the figures. Comment on Blackboard those things I have in red bold font. The videos should help you supplement a lot of the presentation. And then the graded project for this week is the week 5 final quiz. All right, so take that on Blackboard. As always, you know where to find me in the School of Pharmacy. You know how to find me on email. Drop in, say hi. I haven't met any of you guys yet, but I assume maybe by this point and when the class is actually done, I've actually met some of you people. Hopefully I have. All right, my throat hurts. I'm done talking. I need to go have a Hershey bar or something like that. Okay, peace out, folks. I will see you next week.